Appendicitis remain most urgent or most common emergency general surgical operation faced by surgeon in practice. Appendicitis is more common in developed countries, specifically due to low fiber, high fat diet. Appendix is first identified at 8 weeks of gestation as a small outpouching of the cecum. As gestation progresses, the appendix becomes more elongated and tubular as the cecum rotates medially and becomes fixed in the right lower quadrant of the abdomen. The appendix is derived from embryonic midgut. It originates from the posterior medial aspect of the cecum, and it is supported by the mesoappendix, a fold of the mesentery which suspends the appendix from the terminal ileum. It is a blind-ended tubular structure with variable sizes, ranges from 5 to 35 cm in length. Average length is 8 to 9 cm in adults. The position of the free end or the tip of the appendix is highly variable. The most common position is retrocecal. It's about 60%. 30% of cases it found in the pelvis. Peritoneal location is 7 to 10%. Arterial supply is from the appendicular artery, which derived from the ileocolic artery, that is a branch of the superior mesenteric artery. As the appendix is derived from embryonic midgut, therefore the vascular supply is via the branches of the superior mesenteric vessels. The venous drainage is via corresponding appendicular vein. Both are contained within the mesoappendix. Sympathetic and the parasympathetic branches of the autonomic nervous system innervate the appendix, that is achieved by ileocolic branches of superior mesenteric plexus. Lymphatic fluid from the appendix drained into the lymph nodes within the mesoappendix and into the ileocolic lymph node. The first appendicectomy was reported in 1735 by a French surgeon, Claudius Amiand, who identified and successfully removed the appendix of an 11-year-old boy. Notable advances in surgery for appendicitis include McBurney's description of his classic muscle splitting incision and technique for removal of the appendix in the 1894. In the year 1982, first laparoscopic appendectomy was described by Kurt Sem. Appendicitis is caused by luminal obstruction. Now the question may come, why appendix is much more vulnerable for this phenomenon? This is because of its small luminal diameter in relation to its length. Obstruction of the proximal lumen of the appendix leads to an elevated pressure in the distal portion. This pressure increases because of ongoing mucus secretion and production of the gas by the bacteria within the lumen. Bacterial overgrowth within the appendix results from bacterial stasis distal to the obstruction. With progressive distension of the appendix, the venous drainage becomes impaired, resulting in mucosal ischemia. With continued obstruction, full thickness ischemia ensures, which ultimately leads to the perforation. Time from onset of obstruction to perforation is variable. Most common sequelae after appendicular perforation is the formation of an abscess in the periappendiceal region or in the pelvis. Because the appendix is an outpouching of the cecum, the flora within the appendix is similar to that found within the colon. Infection associated with appendicitis should be considered polymicrobial, and the antibiotic coverage should include agents that address the presence of both gram-negative bacteria and anaerobes. Common isolates include Escherichia coli, Bacteroides fragilis, Enterococci, Pseudomonas aeruginosa, Klebsiella pneumoniae, and others. The causes of luminal obstruction are many and varied. These most commonly include fecal stasis and fecolids, but may also include lymphoid hyperplasia, neoplasm, fruit and vegetable materials, ingested barium, parasites such as the ascaris or pinworm. The pain associated with appendicitis has both visceral and somatic component. Distension of the appendix is responsible for initial vague abdominal pain, that is visceral pain, often experienced by affected patient. Pain typically do not localize to the right lower quadrant until the tip becomes inflamed and irritates the adjacent parietal peritoneum, or perforation occurs, resulting in localized peritonitis, which causes somatic pain. Patients presenting with acute appendicitis typically complain of vague abdominal pain that is most commonly periumbilical in origin and reflect the stimulation of visceral afferent pathway through the progressive distension of the appendix. Anorexia is often present. Nausea with or without vomiting is also present. Either diarrhea or constipation may be present as well. As the condition progresses and the appendiceal tip becomes inflamed, resulting in peritoneal irritation and the pain localized to its classical location in the right lower quadrant. Patient with appendicitis typically appears ill. They frequently lie still because of the presence of localized peritonitis, which makes any movement painful. Tachycardia and mild dehydration are often present. Fever is frequently present, ranging from low-grade temperature elevation to more impressive elevation of body temperature depending on the status of the disease process and the severity of the patient's inflammatory response. Absence of fever does not exclude a diagnosis of appendicitis. Abdominal examination typically reveals tenderness and guarding on palpation of the right lower quadrant. The location of the tenderness is typically over McBurney's point, which is located 1/3 the distance between the anterior superior iliac spine and the umbilicus. The pain and tenderness are typically accompanied by localized peritonitis, as evidenced by presence of rebound tenderness. Diffuse peritonitis or abdominal wall rigidity due to involuntary spasm of overlying abdominal wall musculature is strongly suggestive of perforation. A number of signs has been described to aid in the diagnosis of appendicitis, although these are of historical interest. These are Robson sign, the presence of right lower quadrant pain on palpation of the left lower quadrant. The obturator sign, right lower quadrant pain on internal rotation of the hip. The psoas sign, the pain with extension of the ipsilateral hip. Rectal examination findings are typically normal. However, a palpable mass or tenderness may be present if the appendiceal tip is located within the pelvis or if a pelvic abscess is present. Laboratory studies should be interpreted with caution in case of suspected appendicitis. A leukocytosis, often with left shift, that means a predominance of neutrophils and sometimes an increase in band, is present in 90% of cases. A normal WBC count is found in 10% of cases. However, it should not be used as an isolated test to exclude the presence of appendicitis. In addition to the WBC count, a number of biomarkers have been investigated as additional diagnostic clues to diagnosis. These include C-reactive protein, procalcitonin, interleukin 6 and others. Ultimately, no symptom or sign has been demonstrated to be unequivocally predictive of appendicitis. The same may be said of laboratory tests. For this reason, a number of the clinical scoring system has been developed to serve as a predictive model for the appendicitis. These include Alvarado score, which is the most known, and the others are the pediatric appendicitis score, appendicitis inflammatory response score, and the adult appendicitis score. Alvarado score, which include 8 clinical and the laboratory variables used to assign a numerical score. Symptoms like migration, anorexia, nausea, signs like tenderness in the right lower quadrant, rebound, elevation of temperature, laboratory tests including leukocytosis, left shift. The sensitivity of the Alvarado score of less than 4
is more useful to exclude the diagnosis of the appendicitis with 96% sensitivity, but with higher score lacked the specificity in the diagnosis of the appendicitis. Imaging studies in patients suspected to have acute appendicitis can reduce the negative appendectomy rate, which can be as high as 15%, which includes plain radiographs, computed tomography, ultrasonography, magnetic resonance imaging. Plain radiographs are frequently obtained in the emergency department, but it lacks both sensitivity and specificity for the diagnosis of the appendicitis. It is rarely helpful. Findings that may support the diagnosis include presence of calcified fecalith in the right lower quadrant. Pneumoperitoneum, if present, should alert the clinician to other causes of the perforated viscus. This is not typically observed in case of the appendicitis even with perforation. CT scanning is the most common imaging study used to diagnose the appendicitis. It has sensitivity ranging from 76% to 100% and the specificity of 83 to 100%. The recommended CT imaging technique involves the administration of the intravenous contrast only. Enteral, oral or rectal contrast is not recommended and is associated with lower sensitivity and specificity. The diagnosis of appendicitis on CT is based on the appearance of thickened inflamed appendix with surrounding stranding, indicative of inflammation. The appendix is typically more than 7 mm in diameter with a thickened, inflamed wall and mural enhancement or target sign. If appendicitis is strongly suspected on clinical ground based on supportive history or physical examination and laboratory findings, CT scan usually not recommended. Ultrasonography has sensitivity ranging from 71 to 94% and the specificity ranges from 81 to 98%. Although this varies greatly based on the skill and the experience of the sonographer. The inflamed appendix is typically enlarged, immobile, and non-compressible. The secondary signs such as free fluid, hyperemia of adjacent bowel loops, induration of mesenteric fat, and regional adenopathy may be served to increase the diagnostic accuracy. MRI is typically reserved for use in pregnant women. The study is performed without contrast agent. The diagnostic criteria include appendiceal enlargement more than 7 mm, thickening more than 2 mm, and presence of inflammation. MRI has sensitivity to 97% and specificity of 95%. The gold standard and least controversial treatment of acute uncomplicated appendicitis remains prompt appendectomy. Appendectomy can be done by open or laparoscopic procedure. Operation should be processed without undue delay. Fluid resuscitation as indicated, and the intravenous administration of broad-spectrum antibiotic directed against gram-negative and anaerobic organism should be initiated immediately. The operative strategy for perforated appendicitis is similar to that for uncomplicated appendicitis, with a few notable exceptions. This patient may require more aggressive resuscitation before proceeding to the operation theatre. As with uncomplicated appendicitis, antibiotic therapy should be initiated immediately on diagnosis. Both the open and the laparoscopic approach are acceptable for the treatment of perforated appendicitis. Cultures are not mandatory unless the patient has had exposure to a healthcare environment or has had recent exposure to antibiotic therapy, because these factors increase the likelihood of encountering resistant bacteria. Once the appendix is successfully removed, careful attention should be given to the clearance of infectious material, including spilled fecal material or fecalith from the abdomen. Large volume irrigation has been traditionally advocated. Recent data suggests that simple suction aspiration of the gross purulent may be just as effective in cases of appendiceal rupture. Drains are not routinely placed unless a discrete abscess cavity is present. Postoperatively, broad-spectrum antibiotics are continued for 4 to 7 days in accordance with Infectious Disease Society of America guidelines. Alimentation is begun after return of bowel sounds and passage of flatus and is advanced as tolerated. Patient may occasionally present several days to even weeks after the onset of appendicitis. In these cases, treatment should be individualized on the basis of the nature of the presentation. Rarely, patient may be presented with diffuse peritonitis. More commonly, patient presented with localized right lower quadrant pain and fever, with a history that is compatible with the onset of appendicitis several days prior. A mass may be palpable in children or in thin patients. Immediate exploration and attempt to appendectomy in this patient may result in substantial morbidity, including failure to identify the appendix, postoperative abscess or fistula, and unnecessary extension of the operation to include ileocectomy. This may be due to the extreme induration and friability of the involved tissues. For this reason, treatment for this patient is done via non-operative procedure. Fluid resuscitation is initiated and broad-spectrum antibiotic therapy is also initiated. Then a CT is obtained. If a localized abscess is identified, CT-guided percutaneous drainage is performed. The drainage catheter is typically left in place for 4 to 7 days. Laparoscopic drainage is another option. If a periappendiceal phlegmon is present or if the amount of the fluid present is not sufficient to drain, the patient may be treated with antibiotic alone, typically for 4 to 7 days. Traditionally, after successful non-operative treatment of the complicated appendicitis, patients were advised to undergo removal of the appendix several weeks or months later. The procedure known as interval appendectomy. As interval appendectomy can be challenging and consequently yield a high risk of postoperative complication, thus it should be reserved only for the patient who present with symptoms of recurrent appendicitis and presence of an appendicolith on CT. After interval appendectomy in adults, it has been found that there is high incidence of appendiceal neoplasm. Also, perforated tumor of the cecum may be manifest as similar fashion in the perforated appendicitis. For this reason, colonoscopy is recommended for all adult patients as a routine follow-up. In case of negative appendectomy, in which a normal appendix is identified at operation, there is controversy as to whether the appendix should be removed or not. If this situation occurs, then it is important to thoroughly evaluate the abdomen for other causes of pain severe enough to warrant an operation. The abdominal and pelvic organs should be assessed for any abnormalities. This assessment can easily done with laparoscopic approach, which is a major advantage of laparoscopy over the open approach. Note should be made of any free fluid as such findings may suggestive of perforation. The terminal 60 cm of the ileum should be examined for Meckel's diverticulum, and the serosa of the small bowel for any stigmata of Crohn's disease, such as inflammation, stricture formation, or the characteristic creeping fat appearance of the mesentery. Inspection of the ileal mesentery may reveal enlarged lymph node suggestive of mesenteric lymphadenitis. The sigmoid colon should be examined for evidence of acute diverticulitis. In female patient, the uterine adnexa should be examined for any evidence of tubo-ovarian or salpingeal disease such as the ovarian torsion, tubo-ovarian abscess, endometriosis or ruptured ovarian cysts. If these are all normal, attention should be turned to upper abdomen for examination of the gallbladder or the duodenum. Sometimes it is recommended to remove the normal appendix for several reasons, if the normal appendix is identified at the operation table. Firstly, many causes of right lower quadrant pain may be recurrent, such as the pain from ruptured ovarian cyst or mesenteric adenitis, because it removes appendicitis from differential diagnosis when the patient presents with recurrent right lower quadrant pain. Appendectomy is also advisable in cases of Crohn's disease when suggestive by findings at operation, unless the base of the appendix and the cecum are involved. In addition, abnormalities of the appendix not apparent on gross inspection at the time of operation are sometimes identified on pathologic examination. If the patient is confirmed with uncomplicated appendicitis and the patient has poor operative condition, then patient should be managed with non-operative treatment with antibiotics. If the condition of the patient improves with treatment, then patient should be discharged and monitored for recurrence and advised for outpatient colonoscopy. If the patient remains asymptomatic, then expectant management should be continued. But the patient if develop recurrent appendicitis, then medical optimization should be done and followed by appendectomy. With non-operative treatment, if the patient condition worsen and patient develop peritonitis, sepsis, then medical optimization and the appendectomy should be done. The condition of the patients remains same or stable and there is no evidence of peritonitis, then CT scan should be repeated. If we found abscess, then CT guided drainage might be tried. And if we found phlegmon, then continued IV antibiotic till it resolved. After that, patient should be discharged and outpatient colonoscopy is advised. About the choice of open versus laparoscopic appendectomy for the treatment of the appendicitis is debatable. Both approaches are acceptable. Advantages with laparoscopy, although small, is a lower overall morbidity, reduced wound complication, reduced postoperative pain, and perhaps a slightly shorter recovery time. Also, the laparoscopy allow examination of the entire peritoneal space, useful to exclude other intra-abdominal disease that may be manifested in a similar fashion, such as diverticulitis or tubo-ovarian abscess. Laparoscopic procedure is technically simple in most of the patient, particularly in the obese patient. Slightly high risk of intra-abdominal abscess formation after laparoscopic appendectomy is the negative aspect. Consideration of patient's age and gender may help narrow the list of the possible diagnosis. In children, considerations include but not limited to mesenteric adenitis, acute gastroenteritis, intersusception, Meckel's diverticulitis, inflammatory bowel disease, and in males, testicular torsion. Nephrolithiasis and the urinary tract infection may be manifested with right lower quadrant pain in either gender. In women of childbearing age, the differential diagnosis is expanded even further. These include ruptured ovarian cyst, metal smudge, that means the mid-cycle abdominal pain occurring with ovulation, endometriosis, ovarian torsion, ectopic pregnancy, and the pelvic inflammatory disease. In elderly, consideration must be given to acute diverticulitis and malignant disease as possible cause of lower abdominal pain. In neutropenic patient, neutropenic enterocolitis should be also considered within the differential diagnosis.